Hi, I'm Dr. Felice Gersh, your integrative OBGYN physician. And this episode, I want to talk to you about dose. So, since when does dose not matter in anything medical? What would you say is the best dose of exercise? And how would you know what the right dose is? Well, it's not always intuitive, but we do know that for exercise, 5 minutes a month is inadequate, 6 hours a day in general is too much. Okay, depending, of course, on what exactly you're doing. If it's walking, 6 hours is okay. If you're doing high intensity interval training, 6 hours is over the top. Well, how would you find out? Well, you could do studies. How about that? And they have done studies. And with exercise, it has generally been agreed for moderate exercise, 30 minutes, 5 days a week, and 3 days a week that you do resistance training. Well, that's exercise. What about hormones? What about hormones for menopause? Well, dose matters, but what is most likely to be given? What dose is typically prescribed for both estrogen, estradiol, and what about progesterone? Well, the most common dosing arrangement that I am seeing happening out there is a very small dose of estradiol, usually as a patch, but could be as a gel, occasionally with a compounded formulation of estrogen cream, combined with 100 milligrams, most commonly, sometimes 200, of progesterone given every night. Well, where did this come from? Well, we have to journey back almost 25 years ago to the Women's Health Initiative study, which everyone has talked about umpteen times for umpteen years. I'm so tired of it, but its legacy will not die. Well, after that study was done, hormones were shut down in most places. I begged my patients to stay on them, but about half did, half didn't. And that is because there was so much fear mongering, a horrific time where estrogen hormone therapy was told to be evil, dangerous, increasing your risk of heart attacks and strokes and cancer and dementia, especially breast cancer. Well, we have had that study reevaluated, and even with what they used, it has been shown that most everything was overblown. But anyway, a study only applies to what is studied, not to something else. If you did a study with trans fat and the results were not very favorable, that has nothing to do with omega-3 fatty acid or oil from olives or anything else. It's just what you studied. Well, what about with hormones? Well, after that study, the mantra became avoid them if possible. But if you must give hormones because they're so dangerous, give the smallest amount. The lowest dose became the mantra. And it has stuck big time for a host of reasons. Some of them are financial, some of them are legacy, some of them are easy to prescribe. Anybody can do it because if you don't give very much, you're not going to get very much benefit. You're also going to have very few side effects. It kind of goes together. But it was based on a philosophy, which is just treat symptoms. That's it. And that still is very pervasive. In fact, I hear lectures given by top, high reputation academics saying you just treat to symptoms resolution. That's it. And if they lose those symptoms for whatever reason, age out of them, time experience, they're just lucky, they have better health, whatever it is, you don't need hormones anymore, or don't even need them from the start, because it's all about symptom resolution. Well, many of us, many of us have moved way beyond that. And one of the things that I'm so happy about is that there are so many voices now in the menopause space. For decades, I was just screaming into the wind, menopause is important. Menopause is a huge metabolic shift in women. There are so many consequences to menopause. It's not just about a few obvious symptoms. It goes way deeper than that, way deeper than that. Well, there are many voices that have joined into this chorus. And so more and more, but not enough, but more and more doctors and patients are acknowledging that menopause is very consequential in the life of every woman. That because these hormones are affecting organs throughout the body, when you lose those vital life hormones, there are systemic body-wide consequences. So that's becoming more and more established, and I'm thrilled for that because I was screaming in the wind for so many years that menopause, when it happens, it affects the brain, it affects the arteries, the heart, the skin, the bones, the joints, the muscles, everything. I'd go through every single thing, have live lectures on every single organ system and what happens to it when you lose those vital life hormones. And that's what we want to reduce because we can't stop aging. We want to just temper the effects, slow down the negative things about aging. That's what lifestyle medicine is about. That's what hormone therapy is about. Healthy longevity, quality of life, and dose matters. So, with the mantra of the smallest dose, and in the beginning, and still is for many, for the shortest period of time, we lost and didn't deal with the whole gigantic scope of issues that encompass the whole female body. So if your goal is very simplistic, it's reduce night sweats and hot flashes, here's the thing. The amount of estradiol that it takes to reduce those terrible, I'm not going to minimize the effect on life quality, and they're not good for your health when you get night sweats and hot flashes. It's not good for people. It's bad for the brain. It's bad for everything. But that's not the only thing that is going awry. But if that's the only thing you're treating, then honestly, the lowest dose is the best dose because the very smallest amount of estrogen, in fact, sometimes very little, a whiff of estrogen, of any kind of estrogen, not just the bioidentical estradiol, a whiff of estrogen can, over time, it can take longer than shorter, depending on the dose, will eradicate night sweats and hot flashes. But what if that's not your only goal? What if your goal is healthy longevity? Well, this is where dose really matters, and it's not getting enough light of day because everything is dose related. Just as I mentioned earlier, the amount of benefit to your body is going to vary with how much exercise it gets. Of course, dose matters. Now, once we acknowledge that, yes, there's something about dose, how are we going to know what the right dose is? And what's the goal of it? Well, once again, if your goal is healthy longevity, how would you determine the goal? Well, let's look at women when they're healthiest. When are women the healthiest? It's actually parallels when they are the most fertile. So we'll say in their early 20s. Well, what's going on with hormones in a woman who is cycling, not on any hormonal contraceptives? She's having natural cycles in her early 20s. All her organ systems are optimized and her fertility is at its peak. Why don't we look there if we're going to look for, well, what's the optimal dose of hormones? It's not intuitive. Well, we have tons of data on what happens to the hormone levels in women in that age group. We know that hormones are rhythmic. And that's one of the reasons why we want to do cyclic progesterone. No woman at any age naturally has just a little bit of estradiol and a little bit of progesterone on a daily basis. Static dosing, which is the norm, is not a good way to do it. Now, what does a young, healthy, cycling woman have in terms of her hormones? Well, these have been measured. We have tons of data on it, but it's not the same for every woman. There really is a spectrum of levels that are associated with fertility. But we know this, and we know what typical levels are. So if we look, we know that there are certain levels that are lower during the first half before progesterone, before ovulation, which from the uterine perspective, we call the proliferative phase, the time when the uterine lining is growing and you have a gradual rise of estradiol, then you have a big spike, and that precedes ovulation. After that big spike of estradiol, you get a big spike of the hormone from the pituitary gland called LH, luteinizing hormone. That triggers ovulation, which then triggers the formation of a structure in the ovaries called the corpus luteum, which produces both estrogen, estradiol, and progesterone. Now, during the luteal phase, the production of estradiol is higher on average than it is in the first half. And the luteal phase is from the ovarian side, and from the uterine thinking of for the second half, it's called the secretory phase. So we actually talk about the menstrual cycle both from sort of the ovarian perspective and the uterine. For the ovarian perspective, the first part is called the follicular phase. You're developing follicles, one of which is chosen, the special one, to ovulate. During the second half, then that's called the luteal phase. You make the corpus luteum that makes both the estradiol and the progesterone. Progesterone typically is only made for a couple of weeks, like around 14 days. And during that time, from the uterine perspective, the first half is called the proliferative phase. You're growing the uterine lining. The second half is the secretory phase. Growth stops, and then it blossoms. That's the secretory phase, making the uterine lining perfect for one of two things: implantation of an embryo or the perfect period. Dose matters for all of these things to happen. Well, what are we going to do now that we're menopausal women? Should we recreate the menstrual cycle? Maybe, but we're not ready for that, not ready for prime time. But we can at least do the following. In general, for now, we want a level of estradiol that's about on average where we would be and is commensurate with optimization of bone, brain, cardiovascular, and we do have some data on that. So what is an optimal dose of estradiol? What are you looking for? Well, it's not really the dose, right? It's the level you achieve. Because when we give estradiol, anything through the skin, we need to recognize that the skin was not evolved as a hormone delivery surface. It's designed, evolved as a barrier. The skin is a barrier to keep things out. You're not supposed to have a skin layer that's like a sieve and everything that touches your skin immediately gets into your bloodstream. That would be not good skin. So what they did was patent, they experimented, and that's what is patented for the patches and the gels, the delivery system. You cannot patent bioidentical estradiol. You can't patent something that nature created, but you can patent the delivery system to try to get it through that barrier called the skin. But everyone has different skin. Some people have thicker skin, some people have thinner skin, more or less blood supply, more or less fat, and so on. So everyone absorbs differently. I was involved in the development of the first estradiol patch, not in the scientific development. I was one of the earliest educators on the estrogen patch, the very first one, which was a whole different kind of patch. It was an alcohol reservoir patch. And then when the microdot, the current type of patch development was developed first as an adhesive and then as a micro, very much smaller patches. I was involved with the company making that in terms of educating on it. And I spoke at conferences all over, educating doctors and working with how to get your patients involved using it. That's why transdermal estradiol became second nature to me. And I'm one of the earliest adopters of that because I was involved from the get-go. And here's the thing, they had to patent that delivery system because getting it through the skin isn't easy. And I looked at the original studies that got approval from the FDA for the patches, and the estradiol levels that were achieved in the women's blood when they did the testing was incredibly diverse. It looked like a scattergram, like you had ink and you just scattered it on the wall. And then they drew a line through the middle. That's like your average. But there were many women that had much higher levels, many women that had much lower levels, all using the same exact dose patch, using it in the same general location on their skin in their lower abdomen. So it became apparent that dose matters, but what you get into your bloodstream is really what you care about. And they did studies looking at levels. And it turned out that only the highest dose patch, and this isn't for everyone, because some women hardly absorbed it. And this is still true today. You have to check levels, and we're going to come back to that in a moment. But in the very early studies that got it approved, they found that only the zero point 0.1 milligram dose, the highest patch on the market, that dose, that was the only dose that could achieve levels in the blood of estradiol in picograms per mil that was around 100. And 100 was the level that could actually do the best and grow bone. So you needed to use the highest dose patch. So in general, that's the dose I aim to use. I may not start with that dose, especially in older women, but for younger women that are just transitioning very early in menopause, I want to get them on a dose that gets them to about that level because we have data that that's the best dose for optimization of bone. There are also published papers showing that's the best dose for muscle health and for brain health. They're small studies because nobody's funding them, but that's the dose in terms of giving. But you have to see what you're getting into the blood. So when you look at dose, you have to see what level. And talking about levels, I am so happy that some of the other doctors in the, we'll call it the menopause space, are now coming around to saying, yes, you want to measure levels because the conventional world forever has been saying, you don't care about levels. Why do levels matter? You only want the lowest dose. So the lowest dose that eradicates those night sweats and hot flashes, that's the dose you use. But if you care about optimization of your cardiovascular system, your musculoskeletal system, your neurological system, then you need to use a dose commensurate with similar-ish levels that younger women at their peak health would have. Now, why would it be that you could give an older woman, I'm not saying like 90 years old, maybe, I'm not dealing much with 90-year-olds, but women say in their 50s going into their 60s, and then we can talk about older women like 70 plus, but we'll talk about them another time, okay? But we'll say from menopause up into the 60s. Why would you want them to have levels that are commensurate-ish, it's always ish, with levels of a young, healthy woman? Because the cells in your body don't know how old you are. There are very few cells in your body that are the same ones you were born with. That's why we have stem cells. When cells die, and they all have a lifespan, depending on the organ, they may live 7 years, they may live a few days, okay? But they turn over. They live, they die, they get gobbled up, the old ones by the macrophages, they get dissolved and gobbled up, and then you have to replace them, okay? And you need to have estradiol, by the way, to maintain an optimal stem cell pool and to do all of these things. Growth factors are necessary to grow new tissue. And if we just talk about no cell in your body knows how old you are, when a new cell is born, say it's a bone cell, the average age of bone cells is somewhere between just born up to 7 years. An average bone cell will live 7 years. Now, when a new bone cell is born from a stem cell, it doesn't know how old you are. You could be 50, you could be 55, you could be 25. It's a new bone cell. It doesn't know how old you are. And it's genetically programmed to do whatever it's genetically programmed to do, and it will do it optimally and healthy and everything's great if it has what it needs. That means you have to have the right hormones. That's the information delivery system. It gives it instructions as to what to do. You have to have the right nutrients, micronutrients, macronutrients. You don't want to be poisoned. You don't want to have a lot of chemical toxicities or viruses or any other infectious agent that will mess with it. So you want to have the perfect environment with all the perfect ingredients that are given to the cell so it can do what it's designed genetically to do. Well, I'm realistic. I know that at every age we can't make everything perfect like you're 21 because you do have a lot of exposures. You do have chemicals. No matter how hard we try and we give hormones, it's not going to be the same like what your ovaries do when you're 21. But we can try harder than what's been done. That's for sure. We can always do better. Okay? Well, in order to do that, you got to give the right dose. Those cells They don't know how old you are. They just will do what they're told to do if they have the right hormone levels and they have the right ingredients to work with to make whatever they need to make, whatever protein, enzyme, peptide, whatever it is. So, you want to have optimal hormones at every stage of life, and you want optimal means commensurate with a young, healthy woman. Now, I mentioned growth factors for a second. Estradiol does amazing things in the body, so many great things. And we'll talk another time about mitochondria. I'm very into mitochondria right now, but I want to mention growth factors. I bring that up a lot because growth factors require an optimal amount. If you don't have enough growth, then nothing gets repaired. Growth factors aren't just about growing, they're about regenerating, they're about maintaining, they're about rejuvenating. So you want to have optimization, okay? You need to have growth factors. In the brain, you have brain-derived neurotrophic factor, nerve growth factor. You can have vascular endothelial growth factor to grow and restore your vessels and your arteries and such. You want to have transforming growth factors. There's so many growth factors. We've talked about that, but that's dose related. Now, you cannot rejuvenate one organ. You can't pick and choose. If you're going to rejuvenate your brain, your bones, your arteries, and so forth, your skin, you got to have the right levels of estradiol in your blood. And that's why you must measure levels. You want to get your levels around 100. It could be less and it can be more. It has to be to how a woman feels as well as what the blood level is. We're not just treating a piece of paper with a level on it. We have to see how someone feels. But just recognizing that if you can get it around 100, it can be more. It can be in the 100s, like not only more than 200, but it could be 120, it could be 150, because all those levels are totally within the range of a normal menstrual cycle. And it could be less. It could be 60s or 80s if that's really what a woman tolerates the best. But it should always be always over 50 and preferably over 60, preferably at least 80 or close to it. But you have to do like what works for the woman too. And once again, the dose you give matters, but the dose level you achieve in the blood is the goal. So you have to measure, and more doctors are getting on board with that. I'm so happy when I see that. Now, when you talk about dose, you have to think about rhythms as well, because in a normal menstrual cycle, there's not a static dosing of progesterone all the time. That's why I'm looking into increasing the estradiol level by giving more during the progesterone phase, which is, once again, either the luteal phase or the secretory phase, depending on which word you want to use. It's the same time of the cycle. So we'll talk more about that another time. But in the meantime, through the whole menstrual cycle, you want to give, if possible, and you're using the patch, you want to use, if you can tolerate it, a 0.1 milligram dose. And you want to measure the level to try to get to in the neighborhood of around 100 picograms per milliliter. Now, in terms of progesterone dose matters there too. Dose always matters. So what are we looking for? We're looking at only giving progesterone during the luteal or secretory phase, which is the second half of a menstrual cycle, which means 2 weeks out of the whole cycle. So if you have a perfectly normal cycle of 28 days, it would be 14 days without progesterone, just estradiol, and 14 days with estradiol and with progesterone. That's what we want, because when you have progesterone, it downregulates estradiol receptors, particularly the alpha. It downregulates testosterone receptors. You want to downregulate your testosterone receptors the whole cycle, forever, every day? No, you don't. Okay, now if you look at what are the levels of progesterone that are achieved in a healthy cycling 21-ish year old woman, in luteal phase, that's the only time progesterone is made, except in minutia amounts. That could be a little bit earlier, but that's really minutia amounts. Well, you want to get a level over 10, and somewhere up, it could go up into the mid 20s. It's a big range, but you would always want it over 10. Now, what if you are giving the progesterone orally? What levels do you typically achieve? Well, I've talked about oral. We never want to give progesterone orally because up to 90% of it is converted by the liver into other stuff called metabolites, and only a little bit of progesterone gets left over. You get too much of the other stuff, not enough progesterone. But when I measure it, they're variable, and I'm not saying it's everyone's unique, but typically the blood levels, which is what we are using our dose for, it's to achieve a level in the blood. That dose matters, but you can't just give a dose. You have to see the result, what's getting in. So when you give progesterone orally, often the level is maybe a 3, okay? Well, what if you give it vaginally? Okay, we have a ton of data on that, or even rectally, which we have adequate data on that as well. It's even better absorbed rectally. And when you give it vaginally, it goes through the uterus. We call it first pass through the uterus. So it's really good for converting the uterine lining to a secretory state. And that is very well researched because vaginal progesterone has a long use, current use in infertility treatments like IVF and such. So we have loads of data, and we know that it works, it's absorbed, and it is protective of the uterus. You get good levels. So when I look at the level achieved, I look at both the clinical response. Is my patient getting very good, predictable, livable bleeds, like pretend periods, but they're real bleeding once a month? When you give the cyclic hormones, you will get a pretend period, but real blood. That's a sign that you are getting proper growth factors, which I was just talking about. When you are giving estradiol to get a proper optimal level achieved using an adequate dose, you will rejuvenate every organ, including the uterus. You cannot exclude the uterus from rejuvenation. It's part of the body. You can't put a wall up and say hormones don't go into the uterus. When you rejuvenate the bones, the brain, the arteries, the skin, you're going to rejuvenate the uterus, and the growth factors will grow the uterine lining. You cannot achieve an optimal level of estradiol in the blood if you don't give an adequate dose. And you want to have growth factors for all the amazing things that growth factors do. And in that case, you're going to grow the uterine lining. The only reason that progesterone, even though it shouldn't be given orally, but it's given daily, but the reason it's given daily is to suppress growth. But you're not just suppressing growth in the uterine lining. Progesterone is systemic. It's going to go everywhere. You're going to suppress growth factors everywhere. You're trying to negate one of the most important benefits. So the standard treatment with the lowest dose, that mantra's got to go out the window. The lowest dose is the least effective dose. The most effective dose is the best dose. The best dose is a physiologic dose. It's a dose commensurate with having a healthy, functioning female, like in her early 20s. That's what we aspire to be. Healthy like we're 21. I'm not, living in la la land. I know we can't be 21 when we're in our menopause years, but we can aspire to it by doing things in an optimal way. We eat the right foods, we exercise, we get adequate sleep, we avoid poisons, we work on stress and so on, and we get optimized levels as best we can. And it's evolving. The science is still evolving and how to really optimize. That's why I want more studies. We need more studies. How to optimize hormone delivery. Recognizing that menopause is a very big transformational state for women's health is the beginning, not the end. We have to look at how do we give the hormones to optimize health from that point on. Optimal is what you're looking for. Best, not lowest, okay? So we need to have growth factors for rejuvenation. And you cannot have that if you give tiny doses and give progesterone every day to try to suppress, because progesterone downregulates estrogen receptors, particularly alpha, which is what creates growth. You give the tiniest dose of estradiol, and every day you give progesterone to try to beat down those growth factors from the little bit of estradiol that you're given. That's the goal. Never bleed. Even then, 40% of women will have some point, they'll have some breakthrough bleeding, because it's like drip, drip, drip. Eventually the basin will fill, and eventually the uterine lining grows enough to just become unstable and start bleeding. But that's not what we want. We want to have optimal dose, optimal growth factors for all the other functions of estradiol. You will rejuvenate the breasts. We'll talk about that another time. You will rejuvenate the uterus, which means the uterine lining will grow. And if you grow it, you must shed it. Besides that, we want progesterone to be cyclic, because it turns on and off genes, it turns up and down regulating receptors. This is like the beauty and the magic of female bodies. They're rhythmic, they're cyclic, and there's a purpose in this madness, okay? It's not just about reproduction, it's about optimizing health in every organ system throughout the body. And we have to learn from our youngest, healthiest women in their early 20s and look at what makes them tick. And that's what we want to recreate in terms of the hormone environment. And you will bleed, but you'll optimize hormone levels. So in an ideal world, you would want to get the progesterone levels in the blood to be close to 10. But if a woman has a little bit lower level, because you're going to measure the level the following morning, and it's given the night before. So we know the levels will be higher during the night, and then it starts dropping towards the morning. In infertility clinics, they typically give the progesterone more than once a day. They give it at least twice a day, usually 400 milligrams. But many women can do fine with 200 vaginally, but some need more. Okay, you have to dose and up to what the woman absorbs and how her body works. So you got to look at the clinical response along with the level achieved. But you want to try to get close to 10 when you measure the progesterone level in the blood the next morning, and you want to get an estradiol level that's close-ish to 100, in that neighborhood, but once again, to comfort, to tolerance, so that people can live with it. And if someone says, I don't want to bleed, it's a deal breaker, well, I just want to educate and tell them what they're giving up when they don't have cycles. Because a young woman would be very worried and know something's wrong with her if she stopped having cycles and she wasn't pregnant, she's not on hormonal contraceptive. Just a young, normal, healthy woman who stops having cycles, like, what's wrong with me? Something is wrong with her, I can tell you. A healthy woman in the reproductive years doesn't spontaneously stop having cycles without a reason, and it's not a good health sign, okay? Well, we want to replicate as close as we can the hormonal environment of a younger, healthy woman, and dose matters, and cycling matters. So those are the general levels. In order to achieve the progesterone level I mentioned of around 10, you need about 200 milligrams of progesterone given vaginally or rectally, but I have many patients on 400. In fact, when they did studies, you needed usually about 300 to have complete secretory transformation. But we have cases, there's published studies using biopsies. We know that in terms of protection and levels, it varies even in reproductive age women who are fertile. So a minimum of 200 vaginally or rectally of progesterone for about 14 days. Some people use only 12. I usually use 14. And estradiol to use, like, try to get to the 0.1 patch if you're using patches. If you're using the gel, the 1.25 milligram dose, which is the highest dose. There's no high doses when you're dealing with conventional products, because they were all developed with the idea that less is best. Less is not best. Less is not best unless you're talking about poison. If I came to you and I said, how much arsenic would you like today? You would say, none, please. Well, what if I said you had to have some? Then you would say, less, please. You'd say the lowest amount. I don't want to be exposed to arsenic. Less is not best when it comes to good things, only bad things. Best is best. Well, I already told you what's best. What's in a young 20-ish year old woman. That's what's best. That's what we should aspire to. Can we do it? Nah. But can we get closer than we are? For sure. Levels matter. Doses matter. Rhythm matters. Please talk to your healthcare professional about changing your prescription and accept that you are a female. Embrace it, love it. Cycles are what women are designed to have. You want optimal health? Like it or not, you need optimal hormones.